Good evening, dear delegates and dear students and the faculty who is attending this webinar. Welcome you all to the 188th webinar of the ICA. We are very proud to say that these webinars have been conducted every Wednesday without fail, and soon in a couple of weeks, we will be completing the second century. So really, it's a real proud moment for us, and we feel very honored because when we get the feedbacks of these webinars, they are highly appreciated by the students and the faculty. They're all recorded, and so after a few days, the students can access this on the YouTube, and then they can take down their notes. Today, in our webinar, we have the ICA Grand Rounds, which is the anesthesia for GI endoscopy. Every time in the webinars, we take up some topics which are of great interest, not only theoretical for the students, but also practical in daily practice that we do in all these specialities. As the Indian College of Anesthesiologists, for all of you to know, every year we publish an yearbook, which is available online on the www.meripustak.com, which the students and the consultants can avail. So also, we have our yearly conference, and this year we are going to have the 15th National and the 5th International Conference going to be held in Lucknow, and you can save the dates as 12th to 15th of September. So also for the students to know, we are having a PG assembly in Delhi, which is dated to be 27th to the 30th of July. So students, the registration forms will be available on our ICA website, and you can soon start registering. So coming to the ICA Grand Rounds today, the topic is anesthesia for GI endoscopy. And today we have very, very senior and experienced faculty in this specialty. And to moderate the session, we have none else but Dr. Madhusudan Upadya, who is a very senior faculty. You all know him so well. He was the ex-HOD in the Kasturba Medical College, Mangalore, and is still working there. And we are really very, very proud to have him as one of us here who's contributing to the ICA webinars. So, Dr. Madhusudan, welcome, and please introduce our guest speaker, Dr. Lakshmi, and the other panelists. Thank you very much.
Thank you so much, ma'am, for those nice words. Yeah, I was just wondering when the introductory video was running. I was just wondering, Sanish, how many sessions I have done already for ICA out of the 188?
Yes,
Yeah,
yes.
I think it's nice to be back again, and this time in a different role. It's a grand rounds, and luckily I don't have to tackle surgeons. I have to tackle only a couple of medical gastroenterologists. It should not be a huge problem because we have been quite friendly with them even in our workplaces. We never have this mother-in-law, daughter-in-law relations as we have between the anesthetist and the surgeons. First, let me introduce Dr. Lakshmi. Lakshmi is a medical gastroenterologist. I will suffice to say that she was Dr. Sanish's batchmate throughout and a competitor throughout. When Sanish and Lakshmi used to vie for the top position from 10th to MBBS, and both of them did their MBBS from Government Medical College, Thiruvananthapuram, and then she did MD General Medicine from the same place, went down to SGPGI went up to rather for DM in medical gastroenterology. That is where we are going to have the next ICA conference, Lakshmi, in SGPGI. She worked as an assistant professor with Amrita, and then she joined Jipmer Pondi, and then she joined as a chief consultant at the Gastro Center in Thiruvananthapuram, and she is also attached to SUT Hospital and Cosmopolitan Hospital in Thiruvananthapuram. She has a few publications, indexed publications to her name. And she's actively involved with, obviously, therapeutic endoscopic procedures. We are going to listen to her about the newer advances in the medical gastro and endoscopies, basically. As we go by, we also have another guest from another guest faculty from the US, who was also a batchmate of Dr. Sanish, and who is also a medical gastroenterologist. Benjamin Tharian, is he there?
I'm here.
Oh, yeah. He's a board-certified gastroenterologist and hepatologist in UK, US, and Australia. Interventional endoscopist currently based in Tampa, Florida, USA. It's an early morning for him. He's on his way to work. Therefore, whenever he is free, we will get him on board. And he is unlikely to be with us throughout. Therefore, at the beginning, the flow actually has, as was planned, Dr. Lakshmi will talk to us. She will have a presentation for about 10 to 15 minutes about the gastroenterologist's viewpoint when it comes to the endoscopies. And then as a moderator, I will take you through the anesthesiologist's viewpoint. And then we are supposed to open up the panel discussion where Benjamin, Lakshmi, and Dr. Shyam Sunder, who is an additional prof with Amrita Institute of Medical Sciences, Kochi, is also supposed to join. And whenever, Benjamin, you're ready, I think we will have you on board. May I request Dr. Lakshmi to be ready with her presentation so that we can start off. Meanwhile, for everyone in the audience, we all know that non-operating room anesthesia is one of the more difficult aspects of anesthesia. Basically, you are out of your comfort zones. The OR is where we belong to. And whenever we move out of the OR, obviously, it becomes that much tougher. But as is the practice, the senior anesthesiologists, they get stuck to the ORs, and it's generally the junior faculty who are sent to the periphery for the NORA. Obviously, there will be a senior consultant overseeing or ready to help whenever there is a need. But still, this has been the practice in our country. Junior consultant handles the periphery, where you will have to be on your toes. We are basically like fish out of water when we go out of the OR. Therefore, NORA is not an easy thing to handle. Therefore, whoever does it, I was doing it maybe till about 4 or 5 years ago, and then decided that, I don't have much time to spend in the periphery. Therefore, I'm stuck to the OR. And whoever does the periphery, whoever does the NORA, hats off to them. And now over to Dr. Lakshmi for her viewpoints, and then we will go on from there. Lakshmi, please.
Thank you very much, sir, for the kind introduction. And it's an honor for me to present a topic in this gathering. And it's I'm actually literally awestruck by how you are able to do 188 consecutive webinars every Wednesday. It's really a great achievement, something which I cannot imagine in my specialty anyway. And thanks to Sanish for inviting me. Sanish and me, our association dates back to 1993. So we have a 31-year-old friendship. So without wasting much more time, I think I'll just go into my topic per se. Anesthesia for GI endoscopy, a perspective from a gastroenterologist side. So when Sushruta started doing surgeries in 600 BC, people were there to hold the patient down for procedures. But if you want to see something like that happening in 2024, you can go to any endoscopy room where a lot of procedures are done without anesthesia. And there will be at least 3 or 4 people who are there to keep the patient down while the gastroenterologist is busy doing the endoscopy. So in most government hospitals, almost every procedure is done in this way. And so this is something which anesthesiologists may not be seeing in 2024. So I thought I'll just share this picture. Now, we have come a long way now that in 2024, when we have the facility, we have an anesthetist standing behind. I can easily, be calm, relaxed, and do my procedures. Patient is absolutely fine. Nobody to hold the patient, and I am free to do my procedures, take my time, and do my procedures in peace without having to worry about how the patient is moving. So things have come a long way from the time anesthesia for endoscopy was never an option to the current day era. Now, endoscopies under monitored anesthesia care are routine in many high volume centers, but even now in many centers in India, it's still a luxury. I would say there's a lot of difference between the government and the private sector. In government sector, and especially in SCPJ, when I did my training, it was a duty of the first year DMPG to provide anesthesia for these procedures. So we would give midazolam and fentanyl. That's all we know, and then keep our hearts will be thumping, because if the saturation goes down, the HOD will be angry at us. So it was a very difficult time. Even now in government sector, anesthesia under procedures, endoscopic procedures under anesthesia, many a time because of the busy schedules of the anesthetist, it's not possible. But in private sector, definitely a lot of procedures are being done under anesthesia coverage, and definitely the costs involved are more to the patient. So even today, there are a few patients who say that they would rather do a procedure without sedation because they find the costs also to be high. And availability of the anesthesiologist is also a major issue, which limits the free availability of monitored anesthesia care. In Western centers, almost all the procedures are done under sedation, but that's not the rule in India as of now. Now, the challenges are a lot. As we all know, it's most of the endoscopies are daycare procedures, and majority, they are just diagnostic procedures. So the patient has come without much of symptoms. They are coming walking to the endoscopy room, and whatever consent forms and whatever risk and procedure, everything you tell them, they just don't seem to accept the risk involved. And so if something happens, the whole attitude of the patient and the bystanders, everything changed. The usual dictum was like, the patient came walking to the endoscopy room, and then now how can things go wrong? That is what the usual thing happens. So, and as we all know, most of the procedures are not done in the operating room, but in the endoscopy suite. Anesthesiologist is all alone, maybe with one endoscopy anesthesia technician to help, but otherwise it's an unfamiliar territory for the anesthesiologist. And the procedure which we start in the endoscopy room may end up in a lot of complications. Patient may suddenly start bleeding, and the anesthesiologist has the unfortunate responsibility to keep the patient stable till you can wheel into the OT or into the IR room. So we have so many issues instances where we are not able to do much, and the anesthesiologist has to do a lot of work to keep the patient stable. Now, I would say one word of caution to the anesthesiologist: look before you leap. So in endoscopy rooms, we will always be telling that, okay, to the anesthesiologist, that this is just going to be a 5-minute procedure. I'm going to do it very quickly. You just need a mild sedation. That's it. But things may be different. So before embarking on a procedure for GI endoscopy, I would say that the anesthesiologist should have an idea of a few things. That is the degree of stimulation, how painful or what is the physical discomfort which the patient is likely to encounter, and at what point of the procedure they need the maximum depth of sedation. So if the anesthesiologist has a clear idea of when to give the maximum depth, I think a lot of procedures, unnecessary use of sedation will be avoided. The risk of aspiration is very high in our patients, the GI patients, because even when you do a colonoscopy, the intra-abdominal pressure rises. Even though the patient is fasting, just like the cesarean patient, the patient may be fasting, but still the aspiration risks are very high with our procedures. So the anesthesiologist always have to be careful about risk of aspiration. And the expected duration of scopy. I would like to brush upon the expected duration of common procedures, but it's so variable that you start off with a mild 5-minute procedure, end up in a 1.5 hour procedure, and then the patient has to be kept sedated throughout the entire duration of the procedure. And we should have a clear discussion about the complexity of the procedure. This is something which may not be done always. The gastroenterologist may be saying that this is a very simple procedure, I'll finish it very quickly. But in reality, it may be a really complex procedure. and how much the gastroenterologist experience, are they on the learning curve? These kind of things the anesthetist should have an idea before they start giving sedation. That's what I feel. We don't say it aloud other than in anesthesia webinar. And ideally, we should be using only carbon dioxide for insufflation during endoscopy. In India, many centers we are still using air. And if carbon dioxide is used, the anesthesia medicine requirement is less. And in the government sector and in the not so high volume centers, still air is being used. So if carbon dioxide is being used for insufflation, it's better for the anesthesia point of view also. So all these simple things have to be kept in mind before deciding on what kind of sedation to give. So I thought I will go into some of the common procedures and what to expect in these common procedures. So the commonest procedure, the simplest procedure from the gastroenterology point of view is a diagnostic upper GI endoscopy. So diagnostic endoscopy, upper GI endoscopy, the procedure time is maximum 5 minutes. This is one procedure where the time never, goes beyond 5 minutes. If it's a diagnostic procedure, the maximum time will be about 5 minutes. The patient needs to be in the left lateral position. So if there are any contraindication left lateral position, they should be borne in mind. The most stimulating part for the patient is when the endoscope crosses the upper esophageal sphincter. So when you put in the endoscope and it crosses until it crosses the UVS, the anesthesia must be deep enough to prevent coughing, gagging, retching, vomiting, laryngospasms. All those issues of anesthesia for endoscopy just happen at the time of insertion. Once the upper esophageal sphincter is crossed, then it's a smooth going. Then after that, we need only very light sedation. Usually if a single bolus is given beforehand and the patient is comfortable during the insertion procedure, the rest of the procedure becomes very simple. There is not much need for additional sedation. We are out in less than 5 minutes. Now, the problem with upper GI endoscopy is only the problem of sharing the airway. So we are working very close to the airway, and anesthesiologists are never comfortable because any problem with the airway, we have to pull out our scope and then you have to tackle the airway. So sharing the airway is definitely a concern for the anesthesiologist for a diagnostic upper GI endoscopy. But usually this goes on without much of problems. Then we come to the next common procedure, that is colonoscopy. Colonoscopy, again, we use the left lateral position. But during colonoscopy, sometimes if the procedure is difficult, we may need to turn the patient to supine and sometimes even the right lateral position. So we make sure that there is enough manpower to physically change the position of a sedated patient in the endoscopy room itself, because we may need position changes. It is not always in the left lateral position. Now, in colonoscopy, as opposed to upper GI endoscopy, the insertion of the scope is well tolerated. It's not painful. Unless there is some perianal painful pathology like a fissure or a perianal abscess. Otherwise, insertion of the scope actually does not cause significant pain. It's usually well tolerated. We do not need a deep sedation at that point of time. The procedure time is usually 15 to 20 minutes because our withdrawal times are around 11 minutes. The insertion time may vary. So around a 15 to 20-minute procedure can be anticipated. Now, one thing I have to make it very clear that the pain of colonoscopy is just because of colonic insufflation. So just like the cervix, when it dilates, it causes pain. When the colon gets distended, inflated with the air that we put in, with the carbon dioxide that we put in, that is the point when pain happens. So as we progress and we put in more and more air, the pain happens. And when we manipulate the bends of the loops of the colon, so when the colon is bending at the flexures, when we are manipulating, that is a time when the patient has maximum pain. So a few minutes, 1 or 2 minutes after we start the procedure, that is what when we expect the maximum pain. And anesthesiologists can also put in a word like if the abdominal distension is becoming too much, we should reduce the insufflation so that the patient gets more comfortable. Now, the problem, another important problem with endoscopy for a routine anesthesia for a routine colonoscopy is that we are insufflating gas, so the intra-abdominal pressures will be very high. And sometimes if the procedure is difficult, we call our endoscopy technician to give a little bit of abdominal compression. So in our endoscopy unit, whenever the technician puts the hand on the abdomen to give a compression, the anesthesiologist is ready with the suction, because many a time the moment they give abdominal compression, the patient can vomit and aspiration risk is very high. So the high intra-abdominal pressures and aspiration risk is something which we have to be very careful about. And one thing which is often ignored is that the colonoscopy patients are coming after bowel preparation. So they have had at least 15 to 20 bouts of diarrhea and they may be in profound dehydration status. even though we are giving them adequate fluids orally, many patients are very much dehydrated when they are coming for anesthesia, and many of them may have electrolyte abnormalities because of all the bowel preparation that we have given. So in a CKD patient or that, we should routinely monitor the electrolytes just before the procedure. So anesthesiologist has also to keep this in mind when giving sedation for a colonoscopy. Then we come to endoscopic retrograde cholangiopancreatoscopy or ERCP. ERCP, the problem is ERCP is done many times in critically ill patients. So people with cholangitis, in hypotension, sepsis, on ventilator. So we may have to do procedure in critically ill patients or in the routine elective cases. So when we do in critically ill patients, all these issues come up. And in our centers, most definitely, if the patient is critically ill, the procedure is done only in the operating room and not in the endoscopy suite. Only if a very stable patient is there, it will be done in the endoscopy room. The procedure time is very variable. Some patients we just finish off in 15 minutes. We can take an hour, we can take 2 hours, depending upon any complications happening. So we cannot give any idea of how much time we are going to take at the beginning of the procedure. Now, the important problem with ERCP is most endoscopists prefer the prone position for ERCP. Individually, I prefer the left lateral position because I've been trained in that way. Working in a government sector where there is no anesthesiologist to give ERCP sedation for ERCP. So doing an ERCP in prone was a luxury unless anesthesiologist was available. So we were trained in doing in left lateral. Nowadays, I'm comfortable doing most of my procedures in left lateral. But that's not the case. Most gastroenterologists do the ERCP in prone position. So the risks are high. And usually this is not a diagnostic procedure. It's almost always a therapeutic procedure like stone removal, dilatation, and stenting. So the risk of bleeding, you can suddenly have a spurting bleed from a twig of the gastroduodenal branch. So you can have a sudden profuse arterial spurt also, and the patient can suddenly go into hypotension. So this is one area where the anesthesiologist has to be always on the toes, because once suddenly you can develop a massive bleed leading to hypotension. The other complications like perforation, pancreatitis may not be of much concern to the anesthesiologist. And of course, there is fluoroscopy exposure. So along with the gastroenterologist, the anesthesiologist also has, unfortunately, to have a lot of fluoroscopy exposure during the procedure. And as the procedure becomes longer, the fluoroscopy also gets longer. EUS, I would say something similar to ERCP. Procedure time is highly variable, usually left lateral position. The scope is bulkier. So even during insertion of the scope, the ERCP scope insertion also, you may have difficulties. You may have if the patient is only on conscious sedation, she needs a good bit of sedation during the EUS scope insertion. And EUS, again, usually a therapeutic procedure like biopsy, cyst drainage, stenting. And sometimes one important procedure that we commonly do is the coil and embolization for gastric varices. So gastric varices, any therapy that you attempt in gastric varices, suddenly things can go wrong and the patient can bleed very massively from the collaterals. So if a procedure is done for EUS for a gastric varix, everybody has to be on their toes and blood, everything has to be arranged before we embark on the procedure. Then coming to therapeutic endoscopies, in general, biopsies are painless. There is no pain involved in taking a biopsy. So there's no need for any added depth of sedation. But stricture dilatation at any point in the GI tract, esophagus, rectum, colon, biliary, everywhere, anywhere there's a stricture and you're dilating, it's very painful for the patient. So unless the patient is under GA, if the patient is on conscious sedation, we have to inform the anesthesiologist beforehand that I'm going to dilate. And before that, the depth of sedation has to be increased. And watch out for sudden bleed and hypotension. As we see in the picture, suddenly the spurter will spurt, the arterial spurt will start, and then you will be running around for blood and volume expansion. Risk of aspiration is very high with bleeders. If a patient has come with hematemesis and you are doing the endoscopy, many a time it's a full stomach. Whatever ICU aspiration you do, patient may be NPO for 24 hours, but still the stomach may be full of blood and the aspiration risk is very high. So there has to be a conscious decision where the airway has to be protected before doing a therapeutic upper GI endoscopy in a bleeder patient. Polypectomy, again, massive bleed can happen. And one procedure which is commonly done nowadays is endoscopic drainage of a pseudocyst. As we see in the CT, we have a large pseudocyst and the fluid content will be around 2 to 3 liters. And the moment we drain it into the stomach, we are draining it through the US guided stenting. We are putting the stent and draining it into the stomach. This 3 liter of fluid from the abdominal cavity will suddenly gush into the stomach. So massive aspiration risk and hemodynamic fluxes can happen because of the sudden gush of this 2 to 3 liters of fluid. So if a pseudocyst drainage is planned, invariably it should be done after protecting the airway, because you cannot, keep on aspirating that 3-liter fluid that is gushing out suddenly. So now endoscopies have moved on to third space endoscopy. We are fed up of remaining inside the lumen. So we go to the wall of the GI tract. So POEM or peroral endoscopic myotomy, as we all know. POEM is done only after endotracheal intubation and complete general anesthesia, because we are creating a space in the submucosa. So we are injecting fluid and creating a cushion in the submucosa. And as we see in the picture, the endoscope is remaining in the wall. It is remaining in the submucosa. And we are doing the work on the esophagus. So there is only a longitudinal muscle layer between the esophagus and the pneumomediastinum, and the mediastinum. So whenever we give CO2 insufflation, there will be some degree of pneumomediastinum, capnomediastinum happening. There will be a lot of pneumoperitoneum happening. So the anesthesiologist will have to be handling with the complications. Whenever the pneumomediastinum increases, we have to stop the procedure, let the carbon dioxide get absorbed, and then go on again. Because we are working, staying in the wall of the esophagus, and the separation with the mediastinum is very flimsy. So, and these procedures are done only under carbon dioxide insufflation. Endoscopic submucosal dissection and EMR, these are again not so risky, but they may be very time consuming. And EMR, ESD may go on for about 5 hours. And if an anesthesiologist starts off giving conscious sedation and then pulling the patient on for 5 hours for conscious sedation becomes a real difficulty. So I think for ESD and EMR, there has to be a clear discussion. What is the expected duration of the procedure? And if it's going to be high, patient definitely needs NIA, because many procedures may go on up to 4 to 5 hours. So, and before I wind up, one dreaded complication which I have to share, because that's the nightmare for any endoscopist. Dreaded complication that we have is air embolism, where I unfortunately had the unfortunate experience of had a patient where we could do nothing. Suddenly in front of us, the patient collapses, the hemodynamic compromise happens. Patient was under GA, and in the OT itself, it was we were doing the procedure in the OT under GA with multiple experienced anesthesiologists available, but still air embolism happened so dramatically that we couldn't do anything. The patient went into cerebral air embolism and he unfortunately succumbed. So this is something, air embolism can happen with any endoscopic procedure, even a diagnostic upper GI endoscopy. The embolism rate is supposed to be 0.57 per 1 lakh endoscopies. So if you see the number of procedures going on, it is not an extreme rarity. So embolisms are sometimes mild, but once in a while you get that massive air embolism. Suddenly you don't know which, things may be going very smooth. Suddenly the patient collapses, and air embolism has to be kept in mind when there is sudden hemodynamic compromise. And in that case, one just word of advice is that if the patient is in the left lateral position and you suddenly turn the patient to supine position when there is a hemodynamic compromise, then the embolism worsens. Obviously, through a patent PFO or the ASD, the embolism will go on into the systemic circulation. And in my experience with air embolism, that was what happened. The moment we had a collapse, we turned the patient left lateral. Ultimately, the patient recovered from the hemodynamic compromise, but went on to develop features of irreversible cerebral damage due to cerebral air embolism. So it's a very tricky situation, very difficult situation. Hope that nobody has to face this. And that is one thing which, again, which the anesthesiologist has to keep in mind. When you give anesthesia for GI endoscopy, there is a risk of air embolism, which can be catastrophic and lead to a lot of medico-legal issues also. So I think with that, I'll wind up my session and then take up the discussions later during the panel.
Yeah, that is a very nice presentation, Lakshmi, and it's quite from the heart, basically. And yeah, the bottom line is the discussion to plan the sedation, plan the anesthetic. I think it has to be the discussion. You have to discuss with your anesthesiologist, or we have to discuss with you before we decide what kind of one size doesn't fit all. Therefore, for different procedures and different levels of difficulties, I think we have to be actually on the toes, as you said numerous times. We have to be on the toes. Talking about, just by the way, before we get Benjamin on board, talking about the mishaps, we had two back-to-back air embolisms following ERCPs, where the first one was an elderly gentleman. This was about 5-6 years ago. One happened on a Monday, the other one happened the next Monday. I don't know whether it had any significance, but that old man who was about 75 with comorbidities, he succumbed, basically. But the other person, who was a young lady with gallstones, she also had venous air embolism. And then fortunately for us, she was on ventilator for about 3-4 days, and then she came around. She had even a lap cholecystectomy done within the next month when she recovered. That also had a lot of medical legal implications. Yeah, as you said, we sincerely hope that nobody faces this kind of an emergency on the endoscopic table and then have to face the music of the law later. I have maybe a couple of questions to Dr. Lakshmi. Do you ever practice the ERCP on table and then just turn the patient and then do the cholecystectomy there?
Actually, my husband is a gastrosurgeon, so we have tried that multiple times. But the problem is, after ERCP, because of the air insufflation that we do, even creating putting in a varus needle and creating a pneumoperitoneum becomes difficult because of the intra-abdominal pressures are very high.
Correct.
In some cases, you are not able to put the ports, laparoscopy ports. So
Okay.
then, it is like, you may have to tell the patient that if you are able to put the port, we'll do. Otherwise, we'll do on a different sitting. So it's only those kind of patients. In every patient, we may not be able to do.
Correct.
We have tried in some patients, successful in
Okay.
some and not successful in some. So instead of just going in for because of the high intra-abdominal pressure, you can't suddenly change a lap chole to an open cholecystectomy.
Yeah, the gut is
We tell the patient,
inflated.
if possible, we'll do. That's what we do.
Yeah, the gut is inflated, and therefore you may not be able to get an access into the peritoneum either. Yeah, but are there any centers in India? Because outside we do have, other than your center.
Yes, sir.
Is it
Yes,
a
sir.
routine
People are
practice?
doing. There are people, but the more important logistics is the coordination time with the surgeon.
Exactly.
Coordinating the times of the endoscopist and the surgeon is difficult, and the endoscopists want to do the procedure in the endoscopy suite, and they don't want to come to the OT and do. So in most of the corporates, when we have this discussion in our gastroenterology meetings, what is said that it's very difficult to coordinate the time with the surgeons in the private sector in India. So that is the reason why many people are not doing. In the Western world, that may not be a difficulty. The surgeon will be doing multiple other procedures. Endoscopist is doing 10-15 other procedures.
Thank you so much. We will go over to Benjamin for a while. Dr. Benjamin?
Hey, good morning. Thank you so much, sir.
Hi.
So,
good morning to you. Yeah. What is your take on?
Good evening.
What's your take on doing an ERCP and then supinate the patient and then do the laparoscopic cholecystectomy and do it in one sitting?
So I think we do have the same challenge that Lakshmi said, but I think I do that once in a while, especially when the patient is too sick and the anesthesiologist does not want to put the patient through sedation twice. For example, we have a lot of people with BMI of 50 and 60 and 70. So we don't want to put the patient through anesthesia twice, especially in such situations. Or if the patient is, for example, patient is pregnant, and we are taking a high-risk procedure, doing a high-risk procedure in a pregnant patient who definitely needs cholecystectomy, although she's pregnant. So in such situations, we try to do it intra-operative. But most of the times, as Lakshmi said, we try to do it in a different setting. I do most of my ERCPs prone because all my ERCPs are intubated. All my patients who are undergoing ERCP are intubated. And I would say any patient who is coming for a repeat ERCP who is not likely to be that challenging, or somebody who has got a BMI more than 40 or 45, I'll always do the ERCP as supine. Just mainly for the anesthesiologist, mainly for the airway sake. And sometimes if it is a quick ERCP, our anesthesiologists do not even intubate the patients, so they just do it with MAC. I trained in the UK, so I'm used to doing a lot of ERCPs with conscious sedation, which is not great. The reason being, I know just from my experience that even the cannulation success rate of the procedure and the procedure success rate and the complication rates are much lower when you're doing the procedure with anesthesia. The reason being it's a much more controlled environment, as Lakshmi and yourself mentioned earlier. So yes, the answer to your question is yes, I do sometimes do ERCPs along with the surgeon at the in the OR, although that's not my choice. Again, mostly again the other issue is getting the time schedules right with the surgeon, between the surgeon and myself. And most of the times when you do it along with the surgeon, it's done out of hours because I'm available. I don't have a scheduled list or a scheduled clinic, and I'm available for the procedure at the surgeon's time. So we both sort of work, find a time most often over the weekends or in the evenings outside the normal working hours, just for ease of the procedure, scheduling it. So a couple of things that I wanted to mention, just because I'm running late for the clinic. A couple of things just I wanted to mention before I sign out. Although I enjoyed and I would have loved to participate in the rest of the meeting. We always have a timeout. I'm sure that you have that in the India too, but we always ensure that we have a timeout before all procedures, just to make sure that the anesthesiologists and the endoscopists and all the staff in the room, including the radiographer and whatever procedure we are doing, is aware of what exactly we are signing up for, what exactly we are doing, confirm that the patient is right and the complications that are expected, or whether to make sure that we got all the devices in place. For example, if you're doing a third space endoscopy, as Lakshmi said, we make sure that we got an angio catheter in case there's a pneumoperitoneum to release the pressure on the abdomen intra-procedurally if there is a pneumoperitoneum that's compromising the patient's ventilation. Make sure that the patient gets antibiotics and make sure that everybody has got the leads. Simple things, and make sure that we don't have to go halfway through the procedure running back to the endoscopy lab to look for accessories. So a timeout is always mentioned. That's number one. Number two, the situation here in the US is we do have nurse anesthesiologists as well. For example, for most of the common procedures, in fact, for I would say 95% of the procedures, they're being done by a nurse anesthesiologist who are called CRNAs, certified nurse anesthesiologists. And usually there will be one MD, one anesthesiologist doctor, which covering about 5 rooms. So there will be about 5 CRNAs, and the anesthesiologist basically does the consent, and he's available to help. He or she is available to help if the CRNAs end up with any problem. As you know, the vast majority of times the procedures are pretty straightforward, and if there's an issue, obviously they'll be called in because they are within call's reach. Third thing is, again, we do have to obviously have the trust in the CRNA or the nurse anesthesiologists, and most of them are pretty experienced because we do a lot of high volume. We are a high volume center, and most of these CRNAs are experienced. Otherwise they will not be, as you said, out of the comfort zone in the endo lab. Carbon dioxide, I insisted that when I moved here, we insisted that we should be doing all our procedures with carbon dioxide. So one way that anesthesiologists do, it affects the anesthesiologists is it is less sedation for the anesthesia. But again, when you monitor the CO2 levels, especially for new CRNAs, they will wonder why the CO2 levels are going up. But it's often the CO2 that's leaking, or just the fact that we are using carbon dioxide for our procedures. When you monitor the CO2 levels, it will often be high. So nothing to worry about it. What else do I want to mention? One thing that Lakshmi mentioned, which I just want to mention because of my experience in UK, Australia, and US, is United Kingdom is probably a lot of the procedures being done in the United Kingdom are done with no sedation or sometimes conscious sedation. It's very rare. During my 5 years of interventional GI fellowship in the UK, I can probably think of about 4 or 5 patients at the most who we used anesthesiologists, mainly because of the shortage, not because we wanted, not out of choice, just because we did not have the availability or the luxury. In Australia, all procedures are done with anesthesia. In the US, I would say in private sector, as Lakshmi said, as in India, all the procedures are done with anesthesia. But in the government sectors, I would say anesthesia is used only for really sick patients or those with comorbidities or a long procedure. For example, in ERCP or a third space endoscopy, we definitely will be using anesthesia. We sometimes use sedation procedures using Entonox as well, nitrous oxide as well, especially colonoscopies, and patients do tolerate it pretty well. I did a randomized controlled trial in my previous institution with about 100 patients in both arms, and the results were comparable. And complication rate, obviously, Entonox is pretty safe. although not everybody would tolerate it, and you just need to carefully select your patients for such procedures. What else? Yeah, another thing which I again wanted to mention as a because I used to train endoscopies for interventional endoscopic procedures. I would always alert the anesthesiologist to just ask the MD or ask the gastroenterologist to warn them or check with them before they actually start the procedure. I have seen people just putting the scope in as soon as the anesthesiologist shows up. So the fact that anesthesiologist shows up doesn't mean the patient is sedated. So make sure that the gastroenterologist checks with the anesthesiologist whether the patient is ready before they put the scope in. Because once you mess up the situation in the beginning, early on, it will be a more difficult time for the anesthesiologist to put the patient to sleep. You obviously will end up using more sedation. I think that those are the main things that I wanted to cover. I think most of the other things that Lakshmi has already covered, including the procedure times, the length of procedures, and so on. The pneumoperitoneum, people always worry about pneumoperitoneum and surgical emphysema that happens with third space endoscopy. Almost always it will settle down without us doing anything. And then, as I said, only if it compromises the breathing do we have to put a needle into the peritoneum, basically to aspirate the air for capnoperitoneum. And surgical emphysema. Surgical emphysema is another thing that you should not worry about. It will happen if you're doing the esophageal poem. It will happen. I would say probably about 10 to 15% of the cases, situations will have surgical emphysema. But again, initially I also used to worry, but it will settle almost always because I suture all my endoscopic myotomy defects. I always suture it. Okay. So once you suture it, the whole thing is close sealed. So it's almost airtight. So it will all completely get absorbed, especially with the use of CO2. Was there any specific question for me? I'm sorry that I had to rush.
Yeah, a couple of things. You said the CRNA is anesthetizing. What are how many occasions you have sedated the patients yourself, or your resident sedates?
So for propofol, I do not give propofol because I initially tried to see whether I can get the rights to do propofol, but I was told that for credentialing for propofol, I have to go and assist or work with the CRNA for about 50 hernia surgeries or appendectomies. And I said, unfortunately, I don't have the time for that. So propofol, I definitely don't give it. Yes, conscious sedation with fentanyl and Versed. As I said, I trained in the UK. I've done hundreds and thousands of procedures with fentanyl and Versed. In the US, the chance of us needing fentanyl and Versed, using fentanyl and Versed is very minimal. In my previous institution for conscious sedation procedures, those are the ones that we call as conscious sedation over here. So a patient who is obviously at a lower risk of aspiration, I used to use fentanyl and Versed or alfentanyl or whatever is available to us. So yes, I not in my current job. In my previous job, I did used to use fentanyl and Versed myself.
Have you ever done any ERCPs in the supine position?
Absolutely. So as I mentioned earlier, almost all my pregnant females, whenever
obviously,
yes. ERCP, I do it supine. Then anybody with a BMI more than 45, or whenever the patient is very unstable on multiple pressors, or the anesthesiologist is really concerned, the patient has got an arterial line. Once the anesthesiologist starts saying that the patient needs arterial, and you know that this patient is sick. So that's how I assess the patient. So when the patient is critically unwell or unstable, absolutely, we'll always do the procedure.
Yeah, that's right. No, I always felt that if a gastroenterologist tries to do an ERCP in a supine position, it is akin to I trying to intubate in a prone position. It's as so difficult.
It is technically challenging, but again, the thing is that once you start, just like Lakshmi says, I can't imagine doing ERCPs in the left lateral position. So it's what you're used to. It's what you're used to. Once you start doing it on a regular basis,
you can do it in all three positions.
Absolutely,
yeah. True.
Cannulations are easier with prone, but in supine also, I don't think I have not had a case like just because the patient was supine, I couldn't do, and then you had to change position and do. I don't recall. Like it is actually almost always you can do in supine also.
But I have never intubated in the prone position.
I hope you never have to.
Yeah, exactly. That's great. Great having you, Benjamin. Sorry we have kept you waiting for this long.
That's okay. No problem. Thanks for accommodating me.
Yeah, thank you so much.
Have a great opportunity. Thank you so much. Thank you.
Have a great day. Have a great day.
Thank you. You too. Thank you. Bye-bye.
Bye. Okay, bye. Yeah, before we take the next questions. Lakshmi, can you take a break? We will come back after my presentation.
Yes.
Is it okay?
Yes, sir. Yes, sir.
Yeah. Because then I should not be in a position where I can't finish my presentation. It's already nearing 8. Yeah. With Sanish's permission. Okay. Yeah.
Definitely, sir.
Yeah, as I said in the beginning, anesthetizing a patient in the periphery is one of the most demanding job, where you need, as I said, we are kind of fish out of water, and we have to either find the water, or we have to make sure that the periphery also remains as safe as the OR is. It's quite difficult, but still we should be able to prepare ourselves and get the patient ready for the procedure. There is nothing like a short procedure under general anesthesia. General anesthesia is general anesthesia. The patient needs to be evaluated, prepared, and then optimized, and then finally we look after the sedation or anesthesia part of this. Therefore, there is no compromising the patient's safety at any cost, whether it is in the OR or outside the OR. Therefore,
excuse me, sir.
Yeah.
Can you go to the slideshow mode, sir?
Yeah, I will. Yeah. Obviously, we have to look at the patient has to be well informed and educated about what to anticipate. As I said, that the patient should be well aware that there's nothing minor. The procedure is not maybe minor, but the anesthesia or the sedation is not. The complications associated with each of the procedure can be as grave as it could be. And you don't, as Dr. Lakshmi said, most of the procedures are day cases and we don't admit them. But somebody with the significant comorbidities, or the people who have already had earlier, they had the therapeutic procedures done on them, they need to be admitted. They cannot remain the day cases. And even when you have an outpatient coming for a procedure, and there should be somebody escorting the patient home, somebody responsible escorting the patient home. And you should find out how and who will take the patient home and who will take care of the patient at home. Because the anesthesia, even if the patient passes the straight walk test, then even then you have to make sure that the patient is taken care of till the last molecule of the anesthetic is still in the body. And informed consent for any procedure, sedation or no sedation, when you stand by, you provide the MAC, you have to make sure that the informed consent is signed by the patient, and it is witnessed by a responsible bystander of the patient. The patients are kept fasted, and the patient has to be fasted for 6 hours and 2 hours for liquids. And then the bowels are also prepared, but still the patient's upper GI also has to be emptied. The history and the physical examination will remain the same as with any other case. Rule out the pregnancy, as Benjamin kept on stressing on. The pregnancy, obviously, it also dictates the position in which the surgery has to be done or the procedure has to be done. And the rest of the things, obviously, we have to find out from the patient and the relatives. The risk of aspiration, as the stomach is inflated or the abdomen per se is the gut is inflated, obviously the risk of aspiration is much higher. Therefore, you have to be concerned about the nil by mouth time. And as such, if the patient is pregnant or the patient has ascites. Who are the patients who need the special care? The elderly, the patients with severely limiting heart disease, the cerebrovascular disease, significant lung disease, obviously whoever is crippled, and then if the patients have acute gastrointestinal bleeding and cardiovascular compromise, if they are hemodynamically unstable, if the patients have severe anemia, morbid obesity, and then if they present to you in shock, they have to be cared for specially. And they have to be adequately questioned and then investigated. And the routine investigations have absolutely no role here. And it is said that routine pre-endoscopy testing will not alter the risk of planned procedure or outcome. Therefore, just ordering for investigations and waiting for the reports is not going to decide or determine our outcomes. It has to be based on a patient's medical history and physical examination as it happens as it should be in the OR. How will you manage the patients? One of the things is most of the ERCP rooms or endoscopy rooms are absolutely congested with a lot of gadgets inside, be it the anesthesia workstations and anesthesia monitors, or the scopes and the gastroenterologist monitors, or the CM or radiation. The room is packed, but make sure when you design, at least you have a 15 to 15 room, and the layout should be something like that. Anesthesia cart and anesthesiologists have to be at the head end. And depending on which position the patient takes, the scopist, endoscopist will occupy the sides, and his or her assistant will also be on one of the sides. Make sure that there is space for you. As such, the airway is compromised, and if you have difficulty in accessing the patient, it becomes all the more difficult when the patient has a catastrophe happen. As I said, NORA is a difficult situation, and unless you have good space available to you, it becomes very difficult for you to work. And the risks of remote anesthesia is always there, and you don't have, as I said, access to the patient or the patient's airway. In case there has to be a difficulty, if the patient desaturates, then you should be in the close proximity to the patient to maintain the airway. What are the positions which the endoscopist prefers? Are obviously the prone and left lateral or supine. And I'm not that fortunate yet to see any of the ERCPs done in the supine position. I would one day love to go and anesthetize Benjamin's patients when he's doing it supine. Yeah, the prone, whenever you prone the patients, make sure that the patient is proned systematically, and there have to be bolsters under the pelvis, under the chest, so that the abdomen is free to move. There should not be any compromise when you prone the patient, and patient has to be comfortable, and then you have to be comfortable. All right. The patient has to be adequately strapped in case when you sedate the patient, and if the patient has to come out of sedation, patient cannot be sliding off. You need the bite blocks. Obviously, the endoscopist by the side will perform the scopy while standing by the sides of the patient. And you still have to occupy the head end, whether to give a little bit of a jaw thrust, or you have to maintain the airway when the patient starts desaturating. Prone is most commonly used for the ERCP. And obviously, unless you sedate the patient deep, you need the cooperation of the patient. And whenever you position the patient prone, the IV lines may be displaced, and whenever the patient is moved around, again, the IV lines may get displaced. The frail and the elderly patients and post-cholecystectomy patients who have acute post-surgical pain, it's quite difficult to prone them. What are the contraindications for proning? When there is significant aspiration risk, the patient is obviously advanced pregnancy. If the patient has a cervical spine disease, and when the patients are critically ill or cardiopulmonary compromised, and they have the raised intra-abdominal pressures like with tumors or ascites, all these situations, proning them comes with inherent hazard, and you should not be proning these patients, or if at all you prone them, it has to be with extreme caution. This is the left lateral, which obviously will be very comfortable for an anesthesiologist after the supine position. When the patient cannot assume the prone position, left lateral decubitus is an ideal one, but it's quite difficult to maintain the deep sedation when the patient is in the lateral position. Supine position, as Benjamin said, it is reserved for the critically ill patients, because any change in the position may cause negative cardiorespiratory effects and the patient might crash. The indications for supine only is active vomiting, if the patient has a known gastrointestinal outlet obstruction, high aspiration risk and acute severe pancreatitis, if the patient has a C-spine disorder, this difficult airway or altered airway anatomy. But for an endoscopist, it's the most difficult position technically. The monitoring, we never compromise. The patient has to have the standard monitoring, including NIBP, the heart rate, oxygen saturation, and then ECG. And if possible, we can also do the end-tidal carbon dioxide monitoring, which also will be a part of the minimum mandatory monitoring standards soon. You have to have a working venous access, and patient has to have been hydrated well, and there should be a running infusion. The patient has to receive oxygenation, and you should be able to monitor the oxygenation throughout. And the continuous presence of an anesthesiologist is mandatory, even if a registered nurse, the CRNAs give the sedation. It's always mandatory that, or a gastroenterologist providing the sedation himself, somebody who is trained in ACLS has to be around. Even if the person is common for a couple of rooms or more than a couple of rooms, make sure that somebody, preferably an anesthesiologist who is trained in the ACLS, is around to maintain the airway and to manage any kind of cardiac eventualities. We have to have an anesthesia workstation and the emergency drugs trolley. We cannot compromise. You cannot work with just an self-inflating bag and then masks. And defibrillator has to be handy at high-risk patients, or maybe all the patients. The choice of anesthesia depends on how fit the patient is and how familiar you are to the patient and the situation and the disease, experience of the endoscopist, and type of the procedure, and then position which the patient is going to assume, and then the environment. Based on all this, we have to decide about the sedation, no sedation, mild sedation, moderate, or endotracheal general anesthesia with an endotracheal intubation or supraglottic airway devices. Ultimately, we have to have a patient who is comfortable, hemodynamically stable, and he should not have any respiratory complications. For an endoscopist, it has to be successful. Endoscopy has to be successful, and it has to be easy to perform for the endoscopist. The anesthesia, the goals are deep sedation with TIVA is mostly practiced. You have to maintain the oxygenation. Adequate analgesia has to be provided. Dr. Lakshmi has listed out which are the most painful times, occasions when the scope goes in. At least at that time, the patient has to be analgized well. If at all you see the desaturation, it's better that it's safer that you don't, but it's the most common adverse event. And intubation is in exceptional or high-risk patients only. The options to you or the techniques are topical anesthesia, intravenous sedation, general anesthesia, and then just the MAC view standing by. Topical anesthesia, you can use viscous lidocaine or spray. Make sure that you don't overshoot the toxic dose of local anesthetic when you use this. The advantages are there are no adverse events unless the last happens. You should not be using that much of 10% lignocaine spray into the oral cavities. Patient can communicate throughout, and the recovery time is quite shorter, and there is cost effectiveness, and it's suitable for ambulatory case. And if the patient wants to go home, patient will be street fit within no time after the procedure. But the disadvantages are the patient satisfaction is not up to the mark, and obviously the endoscopist will not be happy with the patient gagging and patient complaining throughout. It's unsuitable for a complicated endoscopy or endoscopy of longer duration. Obviously, in children and non-cooperative patients, you cannot be trying topical anesthesia. Most commonly practiced is the intravenous sedation. There is early recovery, low cost, and very few anesthetic agents are used, and then there is short hospital stay. Disadvantages are obviously that suppresses the cardiovascular system. Hemodynamically, the patient can be uncomfortable, and there can be respiratory system complications. There's limitation in severely painful, therapeutic, or complicated case when you can't maintain the depth of anesthesia at all times. And it's again unsuitable for prolonged procedure. The complications, obviously, you know, it's hypotension, brady, arrhythmias, the hypoventilation, airway obstruction, hypoxia, hypercarbia, and apnea. This is what you have to watch for. In the high-risk patients, suffice to say that you have to monitor the patient very well throughout, and there should be low threshold for intubation. If you think the patient will remain hemodynamically unstable and the patient can tilt, the balance can tilt downwards, you should always intubate the patient and take control of the patient fully. This is what Dr. Benjamin was talking about, non-anesthesiologist administered sedation. You have to be extremely careful when, as he said, the CRNAs are trained to give the propofol sedation. But even then, it's very difficult to give deep sedations. Therefore, it will be minimal or moderate conscious sedations. Whenever you talk about the conscious sedation, what springs up is dexmedetomidine. It's not only the midazolam and short-acting IV narcotics like fentanyl or remifentanil. Dexmedetomidine is also a very good option to use in endoscopy rooms. But whenever I do the upper GI scopies, colonoscopies, or ERCPs, my choice is a little bit of benzodiazepines, midazolam, fentanyl, and then I use a combination of ketamine and propofol, ketofol. There are quite a few papers which talk about the safety profile of ketofol, and I have always found that the patients are hemodynamically stable with the ketofol, and then the respiratory depression also doesn't happen, as the apnea will not happen as it is as common with propofol alone. All right. Even when a non-anesthesiologist is sedating or endoscopist is sedating, you have to make sure that anesthesiologist assistance is required when there is a prolonged or therapeutic endoscopic procedures requiring deep sedation, when there is anticipated intolerance to standard sedatives, and the patients belong to ASA 3 or greater, and increased risk for airway obstruction because of anatomic variation. The depth of sedation, I was talking about minimal, moderate, deep, or general anesthesia. Suffice to remember that airway has to be managed mostly with general anesthetic, and it's the safest for the patient when they are sick or when it's a prolonged procedure. And obviously, when the third space endoscopy happens, general anesthesia with an endotracheal tube is the best way to manage. And cardiovascular, there will be cardiovascular depression, but you can control them well. When you talk about the bispectral index or entropy, general anesthesia, it will be around 40 to 60. Deep sedation, it will be anywhere between 60 to 70. And moderate will be 70 to 80. And minimal sedation is 80 to 90. Minimal sedation is actually absolutely treacherous for the patient as well as the endoscopist. The newer airways which are in the market are endoscopic oropharyngeal airways, where you can place this and the scope can go in through the point number 2 there. And the tri-air endoscopy airway device. Then the commonly used airway gadget now is LMA Gastro, and it allows the passing of an endoscope through the LMA. The VBM endoscopy mask, which also allows the passing of an endoscope through the mask. You can oxygenate well as well as when the scope goes in. OxyGuard oxygenating mouth guards are available, and VBM gastrolaryngeal tubes are also available to us in the market. Post-anesthetic management, it's just routine like with any other anesthesia. Routine recovery care is needed. Appropriate and available equipments are the same. The intraoperative monitoring have to continue, and in the recovery area also you have to have the resuscitation equipment, and the post-op management is needed. Pain management is needed. Patient should be monitored for about 1 to 2 hours till the drugs wear off, and then when the patient's throat allows him to swallow, you have to allow the oral intakes. But if the gallstones have been removed or has been stented, you better keep the patient overnight in the hospital. Don't discharge them. Okay. You have to look for the complications, and one of the most dreaded complications, as Dr. Lakshmi said, it is the venous air embolism. And I also talked about our experience with venous air embolism. It is quite difficult to manage when it happens. Therefore, it's very difficult. All the other things are under our control, and when the patient is insufflated, if the VAE has to happen, will happen, and you should be open to manage them. All right. That much is my presentation, and then hope we have both of us together, we have covered a lot of issues about the sedation and anesthesia, and then the complications, and then what a scopist does, including the second space endoscopy and third space endoscopy. Most of the hospitals in the private or the government sector now, we do have the third space endoscopies available. It's like till 1970s, it said that anesthesia dictated the growth in surgery. And when the endoscopy started, laparoscopy started, the surgeons started moving towards laparoscopic surgeries. We had to adapt to anesthesia, and we had to adapt to the surgical challenges. Then onwards, 1970s onwards, we have grown based on the growth in surgery. Therefore, when the newer things appear in the market, like most of the centers, as I said, ultrasound, endoscopic ultrasound is routine, POEMs are happening routine. Therefore, we have to be aware and alive to the situations. Yep. Now Shyam Sunder, Dr. Shyam Sunder, who is an additional prof with Amrita, is with us. I request Dr. Shyam Sunder, in case when you are in endoscopy and the scope is inside and the patient desaturates after your sedation, obviously it is deep sedation. Let us presume that there is no aspiration and the patient desaturates. How will you manage?
It depends on the procedure, first of all. and at what stage they are. But the first step would be to ask the endoscopist to remove the endoscope and based on what position the patient is. ERCPs in our institute generally are done in the prone position, and we do not intubate all the time. So Dr. Anup Koshi is our senior endoscopist, who's a colleague of Dr. Lakshmi. So, I mean, we generally do it under sedation only, deep sedation, of course. And our choice, like you said, has been the ketofol is currently, and we also mix it up with a little bit dexmedetomidine. It depends on, I personally don't go and give anesthesia, just we cover it and our junior consultants and the SARS go. So the mix has been to give propofol with ketamine and to begin with a little bit of dexmed. So if the patient desaturates, obviously is to pull out the endoscope if that is okay at that point of time. And then if not if required, most certainly we would like the patient to be supine. In the left lateral, it is easier to do that, but more often we are in the prone position, so that's not going to happen. So somehow try to assist in the same position with bag and mask, start with that, and see if that improves. That it doesn't improve, then we are in trouble. But many a times does improve with this. Maybe at this point of time, since we are taking control of ventilation, we would actually deepen a little bit so that we don't want the patient, coughing out, and that adds on to the desaturation. Would like to take full control of assisted ventilation at this point in time. So we deepen it a little bit, try to assist in whatever the position the patient is. If continues to desaturate, we have to supine and go ahead with respiratory assistant, maybe intubation. That would be how we would do it.
Yeah. Basically, when the patient is when the patient is desaturating, and if it is beyond our comfort zones, obviously we would like to ask endoscopist to pull out the endoscope and then manage the airway just like we do. The trigger to supinate the patient should be immediate. Basically, you should not wait till the saturation dips to say 40, 30 and then try to intervene. Would you intubate the patient, or would you just bag mask the patient and then
so the first step is to bag mask, definitely.
Yeah.
It's
And,
not that we straight away go for intubation, but then saturation has to come up, and the level that it has to come up is 100%, nothing less than that, especially when we are bag masking. And if it is there, and then we could try to make them take spontaneous breaths and see if it's maintaining at that. But with return to spontaneous, with desaturate again, maybe that's the point we would think of intubating.
Dr. Shyam, have you ever used LMA gastro?
No, sir. Personally, we haven't used. And
Dr. Lakshmi? Dr. Lakshmi?
No, sir. We don't have experience.
It's actually a nice gadget to have, the LMA gastro.
Yeah.
But anyways, most of our ERCPs happen with only deep sedation. Therefore, we may not need. But talking about, this is my experience, talking about desaturation. With the ketofol, I haven't seen any desaturation happening. I don't know, maybe I was lucky, but still no desaturation at all. But my propofol alone, along with the fentanyl and midazolam, invariably I used to have desaturation, and then I had to give jaw thrust and lighten the planes, and then only the patient used to, or increase the oxygenation through the nasal prongs, then only the patient used to improve the oxygenation. Surprising. LMA gastro. Any other gadgets, Dr. Shyam, do you use in the scopy rooms?
We're not used, but there is a thinking, there is a thought process whether using high flow nasal cannulas, but I'm sure that's going to add on to the cost, so that would be a big factor there. But high flow nasal cannulas have been suggested to prevent these sort of desaturations. Not that we have ever used it, but there has been a thinking, but definitely it's going to add on to the cost factor. So maybe it might come up in the future if the cost could come down. And because this we can only use nasal cannulas for oxygenation, providing oxygen deep sedation, because the scope is going through the mouth. So mask is not a possibility. So nasal cannula can give you a maximum 3 liters and not much of FiO2. So high flow nasal cannula is being suggested, not that we have ever used it.
The endoscopy masks,
We haven't
they,
used endoscopy
they are
mask.
available.
They are
I
available.
think
We
it's
haven't used endoscopy mask.
okay. There's a question in the chat box to Dr. Lakshmi. How to overcome the bowel distension if the procedure lasts for longer than 2 hours? Do you give Buscopan? Patient feels uncomfortable post-op.
Actually, the Buscopans we usually give during ERCP because
Yeah.
we don't want much of peristalsis happening in the
Exactly.
duodenum. But that actually adds to the distension because the bowel motility is become slower, and then the whatever gas goes in, it keeps on getting trapped in the small bowel and in the colon. So the situation usually worsen when there is a pancreatitis also happening. The ileus sets in, and then the air keeps on remaining inside the lumen. So CO2 definitely. The incidence of this kind of post-procedure bloating is definitely less with CO2. So all these higher risk procedures we should be doing only with CO2 insufflation and not air insufflation.
Do you use carbon dioxide for all your procedures or just ERCPs? Or
for
OAPs?
colonoscopy and ERCPs we are using.
Carbon dioxide only.
For diagnostic upper GI endoscopy we are still not using.
Okay. Another question for you is, what is the go-to sedation in GI suite in your institute?
I don't.
What is the sedation?
What is go-to sedation?
No, it is go-to is
commonly used.
Yeah, commonly used one. Yeah.
Commonly used one. So we leave it to the anesthesiologist almost always. Midazolam, fentanyl, and propofol. Ketamine is less commonly used in our center. But the three, and I leave it to the anesthesiologist. I don't interfere with that. I have no idea. Whenever, as long as my patient is comfortable, I'm fine with whatever they give. Dextromin is also one of the anesthesiologists uses. I find that very effective because patient is very comfortable with dextromin. Correct,
but it's basically the conscious sedation. Don't you get scared when don't you get scared when the patient stares at you sometimes?
You have confidence in your anesthesiologist.
Oh, wonderful! That's very nice. I hope this statement doesn't stay only for this forum and it goes out.
No way.
Thank you very much. Shyam Sunder, what do you use for sedation? Remifentanil?
No, sir, we haven't got it yet. We've been waiting for it, but once remifentanil comes in, I think we definitely would want to try it out. For currently, it's definitely ketamine with propofol, and we give in initial 0.5 to 0.75 milligrams ketamine and propofol both together, and keep topping both. We don't use midazolam that often. Dexmedetomidine we do give, not as an infusion. Maybe we give it as a bolus in the beginning. Again, 0.5 mics per kg of bolus. Then give ketamine and propofol and continue with ketamine and propofol. That's the most commonly used one.
Anyways, Sanish Sarai, do you use ketofol or Sanish should have put up opinion polls?
No, sir.
Yeah, now you can't. Yeah. I know. Okay. Ketofol?
Yes, sir. Okay. And we keep on topping up, not as an infusion.
Somehow
this duration is unpredictable most of the
time. What duration? The duration of action of ketofol. Okay, endoscopy. Say that. There is a question, Shyam Sunder. I think you should take this. We had bradycardia in a young adult when gas was inflated intra-abdominally. There was a question mark. How common is this complication? Intra-abdominal insufflation? No.
I don't know what's the procedure you're talking about, but if it's bradycardia, I would think it's vasovagal and probably, of course, we tend to give glycopyrrolates. I don't think that was discussed at all because it's in the prone position, especially I'm talking about ERCPs, we tend to give glycopyrrolate. So if that is given, I'm not sure how often we see the bradycardia. So it's some sort of a vasovagal, and I think we would tackle it that way, use atropine, and maybe deepen. They have to continue with the procedure.
Can I put in? Can I have?
Sure,
Can I
sure,
have a
Lakshmi.
comment?
Yeah, sure.
We see the bradycardia very commonly when the patient is not under sedation, because
Yeah.
it's almost always vasovagal. So when we put in
Yeah.
the scope in young patients, they come in for just for sigmoidoscopy.
Mm.
The moment you put in, they start having bradycardia. The moment then you pull out the scope and wait, because I think it's almost always vasovagal.
Yeah.
And
It's
the sedation may not be that deep enough.
yeah, only when the patient is not deeply sedated, the vagal reaction is brady. I think it's better to pull out the scope and then wait. There is a question: what to do when gastroenterologist himself gives anesthetic drugs?
I can't answer. I never ventured into that area.
I have no
so-
issues because see, there are people who are trained to use propofol. In India, it is not a possibility. Outside, it is. As Dr. Benjamin said, you have to work with even a CRNA or a qualified anesthetist, learn about your drugs, and then you can always use sedation. You can always give. In UK and most of the European countries, the endoscopists sedate the patients themselves, but their sedation is generally not propofol. It is basically a lot of midazolam. They use something like 2 to 5 milligrams of midazolam in titrated doses. It's not a single bolus. Single bolus, obviously, the patient will not tolerate. Therefore, titrated doses, they do use. I don't think it's a crime, but when the issue, whoever has asked this question, if he or she is here, what will you do if there is a complication? Like the scopist gives propofol, the patient desaturates, and he cannot do anything because obviously most of our people, the physicians are not trained in BLS or ACLS or even airway management. What will you do then? Don't stay away. You go in and help the patient because patient needs to be safe. Therefore, even if you didn't like the idea of a scopist giving sedation himself, when the patient needs to be saved, I think you have to be there. The egos should not come on the way, because I have seen a couple of times in my life when our endoscopist gave sedation. They generally, please remember that whenever the endoscopist gives the sedation, he errs on the lower side. They don't use too much of propofol. Therefore, the side effects or complications are much less. If at all it happens, please pitch in and help, because the patient needs to be safe.
Just quickly, can I mention an anecdote? So,
Yeah, sure.
something happening. So there was an endoscopy done for placement of Ryle's tube. So no anesthetist involved. This is for someone with not sure what the malignancy, some neck malignancy for which radiation was given multiple times. So we know the airway gets compromised. So the endoscopist wheeled in the patient, gave some sedation. I'm not sure what the sedation was. The patient went into apnea, went into a cardiac arrest, and we did the code blue team was called in, a CPR was done, and there's no way we could secure an airway. And that was one of the very few times when I did an emergency percutaneous tracheostomy, because it was not possible to get the surgical team around so fast. So we somehow shifted the patient quickly to the ICU and did a percutaneous tracheostomy in that patient. So it can be that catastrophic when, that I'm talking about one extreme, and there's only one time I've at least seen this. Regarding the question about whether endoscope is good, sir, you mentioned about propofol, but in the Dr. Benjamin left, I would like him to be in here. So in the US, there's even a terminology called the gastroenterologist directed propofol. It's called GDP.
Yeah.
So it is allowed, but if the case comes to the court, and in US we know each state has their own laws, it's different from state to state. So how a particular judge will interpret depends on, so if the gastroenterologist gives the propofol and something happens, it still can go to the court, and it will depend on the judge, especially in the US. I don't think we have any such legal system that will back us up here. So when there is no legal backing, it would be better to have anesthetist, and we don't have the CRNA practice here, so it might be better that there is an anesthetist around to give deep sedation. Forget alone anesthesia, even deep sedation. I think deep sedation and moderate sedation, I think, should be with an anesthetist's help.
No, I don't think India it's allowed for anybody
absolutely.
else other than somebody who is qualified to sedate. Even mild sedation, if something has to go wrong, if the patient is sensitive to that drug, if the patient has an anaphylaxis, then we are done. If the patient is already compromised, and even respiratory depression with 1 milligram of midazolam also is possible.
Yeah,
And
absolutely.
it's very difficult, because if everybody is adept at securing the airway, then fine. Otherwise,
Can I ask you a question? Do
yeah.
you have flumazenil, and have you ever used it to?
No. That's what one of the guidelines, when you talk about the guidelines for the sedation for or anesthesia for scopies, it actually talks about when you sedate the patient with midazolam, you have to have the antidote. When you do flumazenil, when you use narcotics, you have to have naloxone in the suite. You cannot be procuring it later. But it is just like when they said, yeah, this is who is putting this up? Sanish, obviously. Yeah, exactly. This is what is. I request everybody to go through this. If Sanish can put the link up, I think it should be nice.
It's an open article, BMJ.
Yeah, exactly. Yeah, it's really useful. And let us stick to, anyways, anybody who has asked me things about gastroenterologist sedating, please stick to what the land of the law is. Let us not be adventurous and try to cut corners and save some money. Right? If the patient has to be safe, even if it comes with the you as an anesthesiologist, you can go and work for free. I don't mind, but patient has to be safe. Okay. Yeah. Then somebody asked, have I used remifentanil? No, I haven't, because we still don't have remifentanil in our stock in the pharmacy. Therefore, I haven't used. I would like to use, as Dr. Shyam said, I would like to use once it is made available to me in our pharmacy. I still don't know what is preventing us from procuring it, but we don't have. Yep. And there's one more question about, I can't get that now. How do I access remifentanil? I said I don't have. Any alternative method, sir, can suggest for monitoring the ventilation? No. The mandatory minimum monitoring has to be done at all times. And now we also have nasal prongs which have a ETCO2 cable attached to it. I think it is time we procure them when we try to analgesize or anesthetize the patients in the scopy rooms. We can procure them. They are available in India.
Respiratory rate monitoring probably is available in all the multi-parameter monitors if we have the ECG, but we know the fallacies, the ECG lead could come off and it doesn't give us all the time. So I think if we are going to use any sort of sedation in the endoscopy, especially without an airway, we should be having an ETCO2 is what I would think, because desaturation happens very late. ETCO2 would tell us quite earlier.
Yeah, absolutely. There was a question earlier, I think, why is ERCP not practiced in supine? I just said that I always felt that I trying to intubate in prone position is equal to scopist trying an endoscope ERCP in supine position. Lakshmi, do you do ERCPs in supine position?
Yes, sir. In the high-risk patients, we do. In the
patients.
very high-risk, very sick patients
Okay.
on inotropes, as Benjamin said. It's very rare, but we do.
Yeah. Okay. Yeah, I think.
Now the problem is our chances of successful procedure comes down a bit.
Comes down, yeah.
So then the critically ill patient in whom you have to cannulate, and then it becomes a difficult cannulation.
A little more difficult.
So there are occasions when after trying a lot, some time at supine cannulation, we are forced to somehow take the risk and turn the patient at least to a left lateral position, and then we are able to cannulate. So that has also happened. Supine, we are not sure that we are going to cannulate all the time.
Why don't we intubate, control the patient's ventilation, everything, and then go ahead with the lateral position? Dr. Lakshmi.
No, this
compromised even inhibited patients, they are compromised patients, sometimes anesthesiologist is
Like
not
that.
comfortable putting, even if intubated.
Okay.
I think no more questions in the chat box. Anybody else has any questions? I think I have also run out of my questions to Dr. Lakshmi. It was actually an exciting session where we could get the gastroenterologist's opinion on the endoscopy. But the challenge is obviously to all of you who are online, when the third space scopies pick up, there are quite a few centers now who do the poems, and every bit of for ecclesia cardia, and they also do the, what are the other procedures you do?
The
Lakshmi?
ESD, EMR, and the
Yeah,
full endoscopic full
you do
thickness
them.
section.
You do them.
No, I do only EMR. So
Okay.
the EFT
Okay.
and endoscopic full thickness section is something which is coming up.
Okay. And please keep in mind that it takes a little longer time than the regular procedures. Therefore, better to intubate them and manage, because the patient comfort, the scopist's comfort, and then your comfort, everything has to be taken care of. And a patient with controlled ventilation with an endotracheal tube in situ, I think, is the best foot forward. There's no
we do poem as
compromising.
well, sir. Here we do poem. I'm not sure if you have done EMR here.
Yeah.
Dr. Lakshmi might know if we are
No,
doing
no, it's being done. It's being done there.
Yeah.
It's being done. Okay. So I know that we are doing poem. So for that, it's always under intubation.
Yeah.
Only.
And most of our scopists are on the learning curve. Therefore, it takes a bit longer time. But still, it's okay. Everybody has to learn before they become an expert.
Our chief scopist is Dr. Lakshmi's friend, Dr. Anup Koshi, and he's, at least I would say, he's one of the best.
Yes.
Okay. Yeah. Thank you very much, Dr. Lakshmi, for being a part of this wonderful session. And I thank the ICA and for having given us this opportunity to be online at very short notice. Dr. Shyam came on board only a day prior. At least me and Dr. Lakshmi have been on board since about 3-4 days at least. That's why. But still, I'm sure Dr. Jayashree, Dr. Baljit, you should say whether it has been useful. Yeah, I'm sure it has been a useful session for all the budding anesthesiologists who are going to be experts in NORA. Thank you so much, everyone. Dr. Sanish, Dr. Jayashree, Dr. PRK, Dr. Baljit. Thank you so much.
Thank you, Dr. Madhusudan Upadya, for a wonderful moderation of the topic, which has not been discussed so far in the ICA forum, on the webinars at least. It was a wonderful discussion, where the anesthesiologists came to know exactly what are the requirements of the gastroenterologists, and the gastroenterologists also came to know what are the requirements of the anesthesiologists. And I compliment Dr. Lakshmi for giving us the insights, what are the specific needs of the gastroenterologists, and where exactly do they need the sedation or the analgesia. What are the time points where the patient has more pain as the scope is advanced? I think that was pretty good. She said, look before you leap. Yes, I can assure her that any anesthesiologist would not leap before he so rest assured, no patient taken up without pre-anesthesia checkup and a thorough evaluation of the patient. If it's an elective procedure, emergency procedure, of course, is a different ball game. Yes, anesthesiologist on toes. This was also mentioned. The anesthesiologist, howsoever casual you may look, but anesthesiologists always are on toes. Their ears are always listening to somewhere. Without monitoring anesthesiologist in the OT, it cannot be conceived. And then we had Dr. Benjamin coming in there. We snatched him from his morning run to the office or to the hospital. So he had a lot of inputs, and particularly what are the, how the procedures are done, and what are the kind of differences that he has seen. The endoscopy is being done in UK, Australia, as well as in USA. The concept of CRNA, which he said there in their centers, yes, it's very much there. We don't have it. So I don't think we at this point of time there are any moves to have CRNAs in our place. Anesthesiologists should be there. What I also liked was the communication that he stressed, that there should be a free communication between the anesthesiologist and the gastroenterologist, because if the gastroenterologist wants the anesthesiologist, this is what I specifically would be anticipating, there may be some trouble in this, so that makes the anesthesiologist ready for the service. So I think communication is something which is extremely important. And then Dr. Madhusudan Upadya, I liked one particular sentence of his, which he said 2-3 times, and I think it needs to be highlighted. The procedure can be short. Anesthesia is never short. It's either anesthesia or it's no anesthesia. So surgical procedure or the endoscopy procedure may be short, but anesthesia is never short. So you have to take the patient under anesthesia as a patient under anesthesia. It's never a short anesthesia. It's not a long anesthesia. Anesthesia is anesthesia. With regard to the ketofol that he mentioned, that he didn't have any, he did not encounter any desaturation. I think two things that need to be mentioned here. Of course, his own expertise and also the expertise of his gastroenterologist. Dr. Madhu, will take him for a cup of coffee sometime, because he has made your life very easy. And came in Dr. Shyam Sunder. He highlighted the points very well, as Dr. Madhusudan had put to him, that if the patient desaturates, what needs to be done. I think this was a wonderful discussion, and there are a lot of take-home points from this. Is that we must know where exactly we need to complement need to complement the surgeon. What are the requirements of the procedure, and at what time points should we be more careful about that. I would like to end up saying that the presence of an anesthesiologist is a must whenever you have a patient who is under sedation, and whenever the anesthesiologist is there, he must have his anesthesia machine intact, a functional anesthesia machine, because it's often seen that they say that it's a small procedure, doesn't need a very high-end machine. No compromise here, because that's where we end up in problem. So anesthesia machine should be there, crash cart should be there, difficult intubation, trolley, everything should be there. Defibrillator, of course, should all be there before these procedures are done. And communication is the key to getting the best out of the procedure and giving the best to our patients, so that they are safe there. So thank you so much, Dr. Madhusudan, for wonderful moderation, and of course to Dr. Lakshmi, Dr. Benjamin, and of course to Dr. Shyam Sunder. So till we meet next Friday again, and next Wednesday again.
Yes, sir.
So,
Yes, sir.
So stay happy, stay healthy, and God bless you all. Good night.
Thank you. Thank you very much, sir. Good night.
Good night. Thank you.
Good night, guys. Good night. Good night. Lakshmi, special thanks.
From ICA too.
Yes. Chalo.
Good night, sir. Thank you.
Yeah, shall we meet?
Thank you.
Okay, thank you. Bye.